Well, Bill, thank you very much to Unlin Insurance and Bill and Travis and Betsy and the rest of the gang for having me today. It was interesting when Bill first approached me to talk about one particular subject, and it kind of evolved. So I just want to preface a little bit. I'm going kind of high level here with my presentation, and anytime you have a question, please feel free, or we can wait till the end of the presentation and go from there. So, my name again is Steve Walter. I'm with Professional Benefit Administrators. We are a third-party administrator, or commonly referred to as a TPA. We're located in Oak Brook, Illinois, and we've been in business since 1985, almost going on 34 years of service now. We are privately owned, as Bill mentioned. This is a family business. I'm second generation. My father, Ron Walter, started the company in '85, and basically looking for other solutions to solve employers' problems. Just a quick profile, we have about 135 full-time employees working for PBA and about 40,000 covered employee lives. So, you know, a third-party administrator, basically we are hired by the employer or by a Taft-Hartley fund, somebody that is hiring us, kind of, if you want to think of it as the middleman in replacement of the insurance company. So we're administering the medical plan and a lot of other moving parts, but it's an alternative to the insurance companies. And then also, you know, we consider ourselves since day one a service organization. All right, so we're in the business of providing an excellent customer service experience for your members, but at the same time, over the years, we've become asset managers, okay? Because the cost of these plans are astronomical, as you know, and we'll get more into that detail here in a second. So a little bit of history about TPAs. They've been around since the 60s, 70s. Workman's comp really was very popular with TPAs, still is today. But in the early 1980s, medical TPAs started to become popular. And the main reason back then was, and I've mentioned a couple already, but the one is to operate the administration of the plan at a fraction of the cost of the insurance company. And typically a TPA could operate about a third of the cost of paying what we call BUCAs, which is Blue Cross, United, Cigna, Aetna, in the industry. So that is really what started the movement, along with service and flexibility. Employers were looking for something different and not so much the cookie cutter offerings. Along with that, at the time, claim costs and discounts were not a concern. I mean, nobody was really, back in the early 80s, nobody was really talking about this. I have one of my colleagues, Sheila Carlson, here. She's trying not to heckle me in the front row. But I can remember the day when we first got contracted with our first prescription benefit manager. I can't even tell you the year at this point, but at that time it was all about just taking care of the customers, delivering service. Nobody was even talking about costs, not one word. So it's interesting how the industry has changed. So, what is the problem with healthcare today? I should have been parentheses, it should be plural. All right, there's many, many problems with healthcare today, and we do not have a time for a two-day seminar, and we probably still wouldn't hit all the items. So I'm going to hit again high level on some of the points or problems that jump out at us. So we all know healthcare costs are rising at an alarming rate. Care is everywhere and anywhere. I mean, that statement alone, when I think about anything, you turn on the TV, radio, magazines, you name it, you will see advertising for healthcare. I was driving down, you know, we're in the suburbs of Chicago, and I was driving down the highway to go bring my son back from college the other day, and there was a huge billboard. I just came back from Washington, D.C. last week, and there was a major discussion about this, a billboard on the emergency room wait time. And that billboard said there's 3-minute wait time for the emergency room. So talk about advertising, and advertising to get people in the wrong place. Because that's not an urgent care center, that is an emergency room. Provider mega mergers. We have just here recently in the area, in the state, if you're familiar with the Advocate Health System up in Chicago, they're the largest health system here in Illinois. They have 12 hospitals, and they just recently merged with the Aurora Health System in Wisconsin just last year. So they went from 12 hospitals to 27 hospitals, and that was an $11 billion merger. All right, I just happen to know the people that work there, so I have these numbers. So because of that, and as a result of that, not that particular merger, but it's happening everywhere across the country. We're seeing physician consolidations, practices being bought up by the hospital systems and directing people in their care down the hallway. Along with that, we're also seeing a lot of physicians just retiring. My wife alone had 2 of her physicians in the last couple of years that just said, we're done. We're done with this, and we're no longer in practice, and they just went and did something else. After all that schooling and money they spent to become a physician. And of course, accountable health care, I heard that mentioned earlier today, ACA. There's a lot of good that comes with the Accountable Care Act, but there's also some negatives. Pre-existing conditions is good depending on what side of the fence you're on, but clearly it has cost shifted back to the employer plans that folks that didn't have insurance or couldn't get it because of pre-existing condition, and also the lifetime maximum. The elimination of the lifetime maximum cap, we've seen an influx of claims, and we've done research on some of our own accounts that before the elimination of the cap, $1 million lifetime max, it was rare you'd ever see somebody get that high. Now it's commonplace to have $1 million, $2 million claims coming through the pipeline. Excuse me, I heard just last week in the industry talking to some reinsurance stop loss carriers, claims of $18 million a year, and I just heard another one of $40 million in 1 year. So there's just, I know I'm doom and gloom right now, but I'm just trying to paint a picture. I'm sorry. So, but these are facts. Some of the other reoccurring drivers is baby boomers, and I had to do some math, look online, and figured out that I am the last year of baby boomers. So I'm one of those guys. So when I was born, so baby boomers, you know, of course, more and more boomers are coming through the system right now, and I'll put my glasses on so I don't miss my stats. So there was a recent article on CNBC that stated there's 10,000 baby boomers retiring each day right now, which when I read that, it kind of surprised me. I didn't think it would be that high. Which they're also saying by 2020, that will double the Medicare and Medicaid costs. So just kind of, again, painting the picture and where the money's going and some of the shifting. Poor health habits, Jennifer did a very nice job talking about a lot of the wellness and health habits going on. Excuse me. And diabetics alone have increased by 55% the last 20 years. All right. And another alarming statistic is 1 out of every 4 diabetics do not know they have diabetes because they have not been diagnosed. So as an employer plan, obviously we want to find these folks and get them in the right place. But that is an alarming number. So specialty drugs and inflation, basically medical, I'm sorry, I got ahead of myself, medical inflation is outpacing the CPI, and that's been going on forever. Even though it's stabilized, it's still running around 6% these days and continuing to stay level for the last couple of years. But specialty drugs, on the other hand, when we look at our drug spend, we're seeing our traditional drug spend, it's starting to flatten out. And some of that's competition, the generics coming off patent, et cetera. However, we're seeing a trend in the specialty drugs, about 41% of the plan costs, or of the drug costs, I'm sorry, of the RX costs. So it's expected in the next couple of years, industry projections about 50% of the drug spend will be specialty drugs. And just last night I was doing a little research, and Pfizer just had a brand new drug that hit the market for a rare heart disease, and that they pretty much said it will be $225,000 for that treatment per year for that patient. So, you know, there's just a lot of, these are good things. I mean, these are saving lives and helping people get back on track. However, what is the employer to do? That's really my question today. And of course, cost shifting the government to the private sector. And I've just thrown up a graph here. You know, Medicare, Medicaid, you know, it's been about level for the reimbursements back to the hospitals. So the hospitals are saying, hey, we can't afford this, and there's been an influx of mergers over the years. And you'll see by the graph, now this one's a little bit dated, it's 2009 through 15, but there's been a, I don't know if you can see it up there, a 96% in that time period increase in mergers and acquisitions, and 231% growth in hospitals. So there's a mixed message happening here as far as where the money's going and where it's been. So this particular screenshot is the price markup. So what I'm illustrating here is, if you look at the bottom gray line, that is Medicare costs. And now, these are not made up charts. These are charts coming from the hospitals reporting to Medicare and exactly what their cost is. So this is from 2011 to 2017. So you can see that's been relatively flat. The second line, the PPO allowed line, basically it appears to be around 250% back in 2011, and it's climbed up. I know you can't see the lines there. Climbed up to about just over 300%. So these are the PPO allowable charges that are being paid by the plans. So that's gone up quite a bit. But more alarming is the billed charges coming mainly from the hospitals. So it was running about 350% of Medicare in 2011, and in 2017 it's just over 700%. Okay. I am building a story to Bill's discount story here. So, I don't know, does anybody remember this article in Time magazine? Stephen Brill wrote the article. It was a few years ago now, but it's the first time that Time magazine dedicated the entire magazine to one topic, and that was hospital billing and the egregious practices going on in this country. So the comment, Time follows the money right down to the 10,000% markup. Acetaminophen, you know, will discounts come to the rescue? So getting a 50% or 60% discount off your charge master price of an item that costs $13 and lists for $199.50 is still no bargain. That's right out of the article. Okay, so this it's almost comical, but this is an actual bill, and these are bills off a hospital bill, or charges off a hospital bill. So you can see here, and these are the actual terms on the bill: an oral cleansing device, which is commonly known as a toothbrush, which, by the way, I went on Amazon and pulled down $3.99. You may be able to get a little bit better one, but I think that's mid-range. The hospital bill price is $1,050 for that toothbrush. Cranial support system. I do a lot of flying. I was in the airport recently, and I saw that same neck support pillow, 2 for $12, by the way, $6.79. They billed $450 on that bill. Mucus recovery system. We're after lunch. I don't want to get too much detail here, but $75. You know, normal price about $1.75. And of course, back to the Tylenol story. Tylenol, $513 for one pill. 15 cents is a little high. I found it on Amazon for about 10.5 cents for one pill. So the problem with this picture is, and there's a lot of problems. I go down a lot of roads here that I won't, but I will make a statement that under insurance contracts and the deal between the insurance company and the hospitals, and I'm going through an audit right now on a large insurance company, I won't say any names, that was not supposed to be audited, and the $1.9 million bill was reduced down to $890-something thousand. and now we've found another 400,000 that should not have been billed. Now, according to contracts, we're not supposed to ask questions. Okay? So this is a problem, and under the normal insurance arrangement versus a TPA, that claim would just go through. And by the way, these claims will go through at the 50 or 60% discount. Do the math, right? So here's a little, hopefully I can get this to play. Oh, you guys can't hear it? Okay, let me go back. I'm just trying to wake you guys up, you know, that's why I want to play a little video. Not a video game, just a video. Just for kicks. I'm going to see. Sorry, I'm getting high tech now. This is part of that baby boomer generation thing. Travis, do you have any idea? I don't know. Let me try one more time. I still can't hear it, but I'm half deaf.
Didn't say anything.
Is your volume up on your laptop?
I don't know. There's more of a speaker on this picture. Ready?
Just curious.
We'll get it. We'll get it. We can hear it, but we don't know where it's from.
There are no prices on anything here.
Oh, believe me, some of it's pretty spendy.
Can you hear it?
Yeah.
Oh, that's really gone up.
Stop. I don't need both. Just one or the other. It depends on the price.
Oh, that's called shopping. Here we go. Thank you for coming in. Your bill? Your version will be mailed to you in 30 days. Good luck trying to make some sense of it.
I really love that video. Hopefully it didn't put you to sleep. Woke you up. Because that video really hits home on what we're doing today in our industry. And if you think about it, I'm sure there's manufacturers in here, all walks of life. There is not an item I can possibly think of that we buy in this country without knowing the price, except for healthcare. And that's exactly what that little parody was illustrating. So it says it right there. This is another example, and these are real numbers, by the way. And this is an easy one to pick on. It's a CAT scan, a body scan here. So you can see the difference in price. Here at a hospital, I know for a fact these two top numbers are clearly in a hospital. So for that body scan, a CT scan, $9,887. On the average, $2,839, and on the low end, $557. So how, I say to myself, how does a member have any clue where to go and shop for this? Because if you call the providers, now granted, if you call some of these providers, they might tell you. If you call a hospital, they have no clue. And I was kicking myself a little bit because I have a picture on my phone that I didn't put up here at one of our local hospitals that, funny enough, my wife pointed out to me. She's like, look, Steve, look at that. The prices are listed there. And I looked at it and I took a picture, and there is no way you're ever going to make this out. I mean, as a normal consumer, how much you're really paying for that bill and how much it's really costing you. So, let's see if I can get it going again here. There we go. So, with everything we've been talking about today, and there's been a lot of good discussion earlier, and sorry, let me catch up my notes here a little bit. And basically what we've got here is a chart. Now these are average annual premiums, and it's broken down by small firms. So small firms up here, 3 to 199, or large firms, 200 plus employees on the plan. And sorry, my eyes are going a little bit here, but you can see down here in 1999, my pointer just died, so there you go. So in 1999, the small employer was, for a full family for a year, was $5,683. And I'll just quickly jump ahead. 2018, it's $18,739 for the small employer and $19,972 for the large employer. So that is a big difference. I'm sure there's no surprises here in this room. So what can employers do to help control costs? There's a lot of answers to that. I heard a lot from Jennifer earlier, which I applauded her in the hallway, so thank you for saying some of the things you said, because it is so true. And many of employers, and I would have to guess in this room today, the health insurance expenditure is probably the second or third largest expenditure on the balance sheet, maybe only second to payroll or inventory possibly. So I think we've established it's really not sustainable. So one of the ideas, if you will, or cutting edge solutions that's come out in the industry, and it's been around for a little while now, is called reference-based pricing. And basically what this program does is takes the traditional health insurance plan as we know it today and eliminates the PPO, which sounds just absolutely crazy, all right, if you're not aware of this movement. But basically the plan says, so the employer says, they modify the plan document and they say to the hospital, this is what we're going to pay, okay? So I'll show you, we're going to pay you a reasonable markup and a profit for what you guys are charging. So here's an example. In this example here, hopefully you can see it, is the top-down pricing. If you look at the, this is just a simple bill of $75,000 charge, and the traditional PPO contract is top-down pricing. So if we're real simple math, if we're getting a 50% discount off that 75, the plan's going to pay $37,500. But with reference-based pricing, the benchmark starts at what Medicare pays. Okay, so in this example, for that particular surgery, Medicare is going to pay $15,893. So what the plan's going to say, okay, hospital, we appreciate everything you do and we love you, but we're going to pay you, in this case, 140% of that Medicare. So the plan's going to pay the hospital $22,250 instead of $37,500. So that's just a real simple example, and you can imagine if we take those numbers in my earlier comment of 1.9 million and start doing the math here, what the difference is. So, we love this movement, okay? I'm not here to endorse the movement, but I'm here to educate and make you aware of what's going on with this movement. Because if you saw earlier, the hospitals are reporting their charges haven't changed a lot. However, they're charging 700% of Medicare, all right, and the bills. But they're giving us a 50 to 60% discount depending on what plan you're on, all right? So clearly, if it continues to escalate, this is not sustainable for any of us. So I just happened to be coming back last week from Washington, D.C., and they must have had a Bernie rally. I won't get into politics, but I saw a ton of t-shirts that were saying, Medicare for everyone. I saw at least 100 people wearing that shirt. So that's the movement. People are saying, this is unsustainable, nobody can afford it, out-of-pockets are out of control, Medicare for everybody. Most people in the industry do not believe that's the right solution. However, in the trenches, the pioneers, the out-of-the-box thinkers like TPAs and their consultants have come up with some of these other arrangements. So what we love about reference-based pricing, it has created awareness on price, system, and one thing I didn't even mention is quality. You know, there's a misnomer out there that the higher you pay for your medical care, the better the treatment and outcomes, and that is so untrue. There's tons of data out there that proves that is exactly wrong. So we, some of the things that, or new programs that have come out of reference-based pricing, for those folks that are like it but don't want to go down that road, because the one thing I didn't mention, it doesn't mean the hospital is going to accept that price. I'm sure anybody who's HR in here, I'm sure we have a few HR. HR said there's a, what's going to happen when that patient gets a back bill. Now there's a bunch of new or a bunch of vendors that are out there that are there to help, between the legal and the plan document and help that member through the process. But I will say, and Sheila here in the crowd has had a lot of experience with this. Depending on the employer, and depending on the patients, I will say, it may not be the right solution for you. However, it's created direct contracting. That Advocate Health System that I mentioned earlier, because of reference-based pricing, we've met with them and we've developed a bottom-up pricing structure for members that go into their system. All right, now we're not just pushing people into their system just to get a better deal, but we now know at least what it's going to cost. We still do everything else we do as a TPA, manage the claims and get people in the right direction. We'll get into in a minute. So we really love that it's creating this new movement. A little bit more about PBA and some of the things that we're doing because of the movement, and this has been going on for a long time, but we've created a new program we're calling Focus Care, and you can see that acronym stands for Fostering Outcomes, Creating Unparalleled Savings, and I always like to add service on the end of that. So the one thing that really resonates for us and for people trying to manage this spend is that employees just have no clue what to do, right? I mean, I already told you I'm at the tail end of the baby boomers, so we've all been conditioned, we listen to our doctor, whatever the doctor says, we go down the hall or go to that specialist, and I've been laser focused lately, just with everything I've been learning in the industry, and I've been watching how my primary care physician has been treating me. And basically, I go into my primary care physician, we have a chat, we review things, and anything that's going on, he's quickly writing a prescription to a specialist. By the way, all in the system, all right? And that's what it's become. The primary care physician doesn't know, so they're quickly sending you to a specialist. And some of the newer programs that we've developed with some partnerships with some of our vendors, one's called Joint Strong. And I hate to keep picking on Jennifer, but she mentioned a stat earlier in her presentation, I think it was on the case study, that 63% of the spend on that particular client was musculoskeletal. All right. In our block of business, we're seeing musculoskeletal at around 60%. That of our clients, that's their number one category of spend. The rest of them are second or third. All right. Now, this is an area that we haven't really spent a lot of time on or talked about over the years. And I heard cancer and diabetes and heart. But overall, here's where we're spending a lot of money. There's tons of advertising and trying to get people to go down that road. I personally have experienced, I had a knee surgery, and as soon as I had that MRI in my hand, and I went to two surgeons and had a review, both surgeons said the exact same thing. We really, they put it on the screen, it was really cool, and I was looking at it, and it was a lot of fun to look at and say, what's wrong with my knee? And both of them said the same thing, we won't know until we get in there. Now there's all kinds of stats, all kinds of stories. There's a very prominent physician out of Johns Hopkins that's done thousands of surgeries, and this individual admitted that 40% of the time they go in for surgery, they didn't need it. So they give you a little shave, clean you up, close you up, and you're done. All right, $30,000 later, whatever it might be. The point I'm making here is this is a little bit scary about what's going on with our treatment. The second program is Mayo Complex Care. We've recently contracted with Mayo, so we've got, Mayo's not about discounts, because they really don't give discounts. You ever get a little bit better discount directly with them. However, this program is more about identifying those high-cost claimants, and we've seen it in our plans year after year. The same person that's spending $200,000-$300,000 typically is probably lost within the system, or not getting the right treatment, or trying to find the right treatment. You know, someone like that, we would definitely do a pre-review of that claim file and possibly send that individual up to Mayo. And that's the responsibility of the plan, and the plan saying we will send you to Mayo, and we'll pay 100% for it. A couple of statistics we've learned from Mayo recently, and they're just mind-boggling. 70% of the spine surgeries for folks that have been recommended spinal surgery that go into Mayo, they end up not having the surgery. Okay, 55% of cancer patients that go to Mayo, 55% of them, their treatment plan has changed. All right, and we've seen that over the years, just with all the claim data and management that we do. We've seen cancer patients being prescribed a drug that's not even being used anymore in the industry. It's pretty scary. I'm not saying all providers are bad, but what I am saying is you really need to know who you're dealing with. And this was the scariest one. I had to literally go back and double check this stat a few times. But MS patients, 80% of the MS patients, multiple sclerosis, that go into the Mayo were misdiagnosed. I mean, I couldn't even believe that. I mean, that is just mind-boggling. And think about the drugs, the high-cost specialty drugs these individuals are on. So, one thing I will say, PVA never does anything or recommends anything to our clients until we've tried it on our own population, because we're self-funded, and we've had some really good success stories with that program. Quickly, I won't spend a lot more time. Specialty drug infusion management, you know, this is about interjecting or getting involved early on. Live story, a CEO of one of our companies that we administer, just so happens to sit on the board at the hospital, the local hospital. And unfortunately, he was prescribed 13 infusion injections, and it kind of moved pretty fast. The first bill came through with $73,000 for that first infusion. So I saw a lot of eyes open up. That's exactly what he did too. He's the CEO of the company, and he has to pay this bill. It's a self-funded plan. By the way, after discount, that particular bill was $52,000. And then once we got involved, the hospital found out that we're looking hard and we're digging hard. They came back and offered $32,000 on that bill. End of the story is we got them down the road, exact same treatment plan, exact same drug for $14,000 per treatment. So this is part of what we're doing to help manage the healthcare spend for your members. I'll quickly, diabetic health coaching. We heard a little bit of that earlier too. Very important to keep diabetics on the right path, because if you're diabetic, of course, it causes a bunch more comorbidities if it's not being taken care of under control. In second surgical opinion, I threw this on the slide only because if you remember years ago, for those of you who've been in the business a long time, many of the plans had a list of second surgical opinions. And over time, those have disappeared unless it was a union negotiated or something. But over time, utilization review has taken that over. And you know, it's interesting that now it's coming back. And for the stories I'm telling you today, this is one of the reasons it's coming back, to try to catch that individual, get that second opinion, and try to get them in the right place. And then last but not least, I just want to mention medical tourism. I mean, I don't know what the first thought when you hear that. First thing I think of is going to India or something to go get my surgery. However, that's changed a lot. And I will say, in fact, when I was in Washington last week, I met with the Cayman Island Hospital Group, which is for cost and quality in the top 1% in the world, at a fraction of the price. Now, is the plan going to back that? Is the plan going to put it, pay for that 100% benefit? That's up to the plan and the consultants involved. However, there's been a big movement in this country in the last few years to have medical tourism here locally in the United States. I will say, I always use myself as a guinea pig. I needed a knee surgery, so I did a lot of research. You heard me earlier with my MRI. I didn't finish that story intentionally because what I ended up doing, instead of my selection of at least 100 choices or probably 1,000 choices in Chicago, I ended up getting on a plane and I flew out to the surgery center of Oklahoma, in Oklahoma City. And at that surgery, I gave up negotiating because my wife really wasn't thrilled about this or going with me or taking care of me or dragging my leg around. But at the end of the day, I stopped negotiating cash price at $25,000. Okay? And that did not include the implant into my knee, which I knew because I know the manufacturer that sells it was $2,500. Nobody could tell me what that cost, or the anesthesiologist what that was going to cost, which we all know is a problem. Nobody knows, right? So I got on the plane, went out to Oklahoma City, had my surgery, all bundled, pre and post, 4 months, all included. And I did go back, and I ended up having an injection and a bunch more x-rays, everything else. And I asked the doctor, well, what is this going to cost? He says, nothing, it's all included. I was like, really? Okay, so for $7,100, I had that entire surgery done from a very high quality organization. And I encourage you to look it up. I mean, it's kind of fun. If you go on their website, Surgery Center of Oklahoma, it'll pop right up. All their prices are listed on their website, exactly what it's going to cost you to have your surgery. Okay? So, I'm just full of stories. That's all I do. So anyway, in summary, working with a third-party administrator, it's a little bit different animal than working with an insurance company. There is a little bit more work involved because you're more hands-on instead of just relying on the insurance company to bring you these solutions. And you can see there's a lot of plug and play. I've had some great discussions even at the breaks here today with some of the folks on what can be done. So I won't go through all this, but proactive approach, we really work as a partner with our consultants and with the employers to establish the right plan, drill down on the data. And that's one thing I didn't mention earlier. It's hard to get data out of insurance companies where, bottom line, it's your data. You own the data. So we have all kinds of tools to help with that. So I think at this point I'll end there because it's really not supposed to be a commercial, but just become more familiar with some alternate solutions. Okay? Is anybody waiting? You're still waiting. So, any questions? I know I kept it pretty high level, but more than happy to get in the weeds if anybody has questions.
A couple of questions. Can you deploy all those, can a TPA deploy all of those cost containment plans together at the same time?
Yes, you can. Just like any other new benefit, there is coordination, and the biggest issue is communication. And for the HR folks in the room, you know all about that. It's also about awareness and continuing the campaign, which I recommend working with the consultants to come up with a good campaign to remind people. Internally at PBA, every single phone call, our folks, which we call advocacy folks, instead of customer service, are there to identify and are trained to try to find these issues popping up within that member's life and try to remind them that these programs are available. Because that's the biggest issue. People forget that they even have these benefits.
From the standpoint of customer satisfaction, right? Obviously, we've been caught in the middle of trying to manage an escalating cost that is confusing, A, for the people that deal in it, but really confusing and almost distracting to the fact that employees just don't think about it. They just become blind consumers. Running plans side by side. Well, this is your reference-based pricing option. Understand this is what your risk is, this is what your responsibility. This is the one with all the other PPO and all these centers of excellence and the whole routine program. Is there a way to actuary that cost? Underwrite it?
Yes. If we have the data, we can analyze the data and come up with a projection of what reference-based pricing program would save. And I've had a lot of discussions on this topic. The CEO, CFO, they're going to be very attracted to these numbers. I have a case right now in Wisconsin that we're working on. It happens to be a county very similar to one of the case studies earlier, about the same size. And the difference from going to the plan they're on now to an Anthem plan is about a $1.5 million savings, which is a big savings, right? In that particular model, we can still bolt on some of our solutions. But go to the reference-based pricing, based on the numbers that you saw earlier, that same savings was $5 million. So now we're going to have a discussion, because that's a big variance in cost. So the question is why and what does it take to implement this type of program? Because I will say, reference-based pricing is not for the faint, because there will be issues and there will be pushback, and I will tell you right here in town there is a lot of pushback, and especially when you get into areas like Peoria and the surrounding areas when you only have a few selections. All right. Now that might have an employer say, you know what, that's fine. We'll incent our folks to go outside of the area. I'm not encouraging that, but I'm saying we've seen employers do that. And we will make it very easy for you to get that surgery if you need it. Right? One stat I forgot earlier is a high percentage of these surgeries are unnecessary or misdiagnosed. And they're doing surgeries on the wrong body parts for pain. And it's really scary, some of the statistics that are coming out. So the answer is yes, we can analyze the data and give those projections.
Okay. Other questions? I picked the ones that we would be typically asked, right? How do we deploy this? How do we live with the result? Who's there to help? That kind of stuff. On the pharmacy side, we talked a little bit about the medical spend.
Yes.
But on the pharmacy side, what do you see with the specialty drug advocacy and all this?
Well, we're seeing all kinds of interesting movements. We've seen movements to Canada. We've seen CanaRx is one of the vendors that's out there that's literally shipping the drugs right to, from Canada. Same manufacturers, about a fraction of the price. I mean, this is mainly brand name drugs. There's a plethora of generic drugs here in the country. And maybe you heard my statement earlier that the rank and file, your generics and your brand name drugs are staying relatively level. But with the specialty medications, what we're doing is we're working with some vendors that are taking a very proactive approach. They're literally looking at every single claim coming through. They're stopping those specialty drugs. Because if you notice, I know I'm kind of geeky because of what I do for a living, but I notice every single commercial, which I try not to watch too much TV, but when I do, almost every time I turn it on, there is a drug commercial on. And I always it's a challenge for me to try to figure out what is that drug commercial for, and 80% of the time I can't figure it out. At the end of it, besides all the warnings that it will kill you and everything else, I have no clue what it is. But so those are the specialty drugs, and especially if Phil Mickelson's recommending it, it's got to be good, right? Because then just paying him. So we're using vendors that are taking those drugs because one of the gains, that's where I was going, is to manufacture coupons, right? So if you notice those commercials, a lot of times they say member assistant available. Many times it's a $0 copay or maybe a $5 copay. So the member's paying $5, but on the back end, and I'll give you a live, real example, and actually Sheila was involved with this particular account. There was a drug that was running around $8,700 a month. This is an individual that had $300 a year in medical spend. That's it. And she was paying a $40 copay every month for this drug. And I'll never forget the date. It was April 4th, 2014. All of a sudden they decided, you've heard these horror stories in the industry, they're going to change the price on this drug. And they went up to $53,000 some odd dollars overnight. Okay? So that was an alarming figure, and so we had a powwow with our vendor, and we started working on solutions on how we're going to operate. That particular account had a big laser because of this drug coming through, and we were able to eliminate that laser, help the member, and the employer didn't want to get involved. They didn't want the employee to know that this problem was out there. They just didn't want to have anything to do with it. So we were able to get that spend down. I think it was under $300,000 by the time we were done. Still a ton of money, but there's really not much we could do. There's only 100 people in the world that were taking that drug. So class action suit, all that's gone. I mean, nobody cares because it's only 100 people. So, but with the vendors we're working with, we're coordinating and through kind of using the system backwards, pinging the system to see what that manufacturer will accept. And it's worked, and it's worked well. You're hearing more and more about that today, but we've been working with some of the pioneers in that part of the industry. And there are some drugs that there will be nothing you can do. That example I told you earlier, just read about it last night, $225,000, only a source, and that's their price. They're expecting that's what Medicare is going to pay, that $225,000. So it's a little bit scary, but we have to be involved because back to my story, that individual had no clue to this day that that drug was costing what it cost. He only thought it cost $40 every month. So without any employee engagement or awareness, people just don't know what to do or where to go. So that's part of our job to help them identify and get to the right place.
Right. From a reporting standpoint, what do you do to document these savings programs and the impact to the plan sponsor?
Well, with that particular example, with that one vendor we're using, they will report back exactly what they've saved. One of the games in the industry too, if you're not working with the right payer, is that $5 example, copay. So the member pays $5, but through the back-end claims system, it might come in at $14,000. So that $14,000 gets applied to that member's account. It looks like they paid all this money when they really only paid $5. So this is again part of managing the spend, the corporate spend on the bottom line. But working with the vendors and working with the consultant, we will bring that information to the table, those savings.
Other questions?
We should have got like Nerf footballs to throw at me or something. Wake us up. I know this is tough. So I thank you very much. I appreciate your time.